I don't usually do a lot of how-tos in these videos, and that's because I like to talk about the pathology and not necessarily kind of the lab techniques and so on. But in this case, I wanted to go into some basics in how we give insulin using an insulin pen. And that's just because the techniques show up on a number of different tests, and it's something that you'll have to know for the NCLEX. So I thought I'd just go through it really quickly so you know what's important to know for a test, what's important to know for the NCLEX. So here we go. When I first started working and giving insulin, we had to draw up the insulin out of a vial, and we used like a little 100-unit syringe and pull it up, and then and actually at the time we had to do an independent double check every time we used insulin because it's incredibly dangerous, right? And a few years into working, the hospital changed its entire policy and went to strictly insulin pens. As far as I know, we don't draw it up anywhere in the hospital anymore. These pens can hold up to 300 units at a time, and they're fast. It's much faster than having to draw it up by hand. So there's really no reason to have vials of insulin on hand and then have to draw it up. So that being said, we're going to talk about how to administer insulin using a pen, because most of the places you will work will not ask you to draw them up, and most of the tests you take will want you to understand these basic concepts anyway. So here are the important things we need to know about administering insulin. First, insulin cannot be taken orally. It has to be given subcutaneously or through IV. More often than not, we give insulin subcutaneously. We use IV mostly in emergencies. It's really not necessary to start an IV every time we give somebody insulin, especially when you have patients who are taking insulin. Some of them are taking one long-acting in the morning, one long-acting in the evening, and then 3 bolus injections throughout the day. There's absolutely no reason to have an IV for that. So again, sub-Q is the most common. You always come up against these questions in tests whether or not you should be giving at a 90-degree angle or a 45-degree angle. The answer to that question for insulin, it's going to depend on whether or not they're an average size to larger size person or a very thin person. If you look over here at this cross section of the layers of your skin, this right here, this is your subcutaneous fat layer. That's where we want the insulin to go. We're using a subcutaneous needle. That's 5/8 of an inch. So it's only going to go so far. If you have an average size person, when you use that 5/8 of an inch needle, it goes in, it usually will hit directly right into that fat pad. When you have a patient who is very thin, these layers here can actually be quite small. And so that 5/8 of a needle, believe it or not, will go through that sub-Q layer and end up injecting into the muscle layer. And so when you have a thin person or somebody with a smaller fat pad, you're going to do the pinch, which you do the pinch for both. You're going to pinch the person's skin, and then you're going to go in, instead of at a 90-degree, you're going to go in at a 45-degree angle. And what that does is it gives you a little bit less space to mess up, right? In that case, you're going to, even if the sub-Q layer was up here, if you go in at a 45-degree angle, you're still going to hit that sub-Q layer. We really want it going in that layer. One day I'll make a video on, how the different routes of administration affect the way they spread throughout the body. But for now, it's good enough for you to just understand that the best place for us to inject insulin is the abdomen. Now, The abdomen isn't always possible. There are times when you have a very, very large or very, very sick patient and you don't have access to the abdomen, and it is okay to give insulin in the upper arm. Again, we're looking for that sub-Q layer, so you're going to give it kind of in the area on the inside of the arm where you can pinch. We can also do the thigh and the buttocks. I'm not sure I've ever seen anyone do insulin on either one of these places, but I often see people using the upper arm. Again, it's okay, but it isn't the absolute best for absorption. So test answer, abdomen. It's really, really important to follow a little set of rules here when you're giving subcutaneous injection. And this stuff is really important for a test as well. They tend to ask these kinds of little tricky questions a lot. So first, we don't want to inject into any kind of skin abnormality. So scar, mole, even a bruise, anything like that's going to affect the absorption of the insulin. Interestingly, a lot of people think that they should massage after they give insulin. It's really important. Make sure your patients who are self-administering or family members who are administering insulin know we should not be massaging the area after we give. This will increase the absorption. You massage the area, the blood is flowing much quicker, absorption increases, and then you have a much, much higher risk of hypoglycemia. For the same reason, we want to avoid an area of exercise. So I don't know if your patient is known to, I don't know, get up and do jumping jacks or something, or maybe they like to wash the windows in the afternoon, so they're using their arm. We wouldn't want to give that in the arm because it's the same reason. As soon as you start to increase kind of the movement and the demand for oxygen, then you're going to have an increase in blood flow, an increase in absorption, and you end up having an increased risk for hypoglycemia. I'm not going to go through IV insulin. It's the same way we give most other IV meds. This is what's really important for a test. If you are studying for the NCLEX, it's really, really important to go and look at a step-by-step guide for administering insulin. The NCLEX loves to ask questions where you have to put steps in order. For example, if you're using an inhaler with a spacer, when you take a breath, when you put it on your mouth, when you blow out, when you take another breath, when you press down, like it's very, very specific, and these are the questions where people mess up a lot. So I would do that this is one of those areas where I would go and make sure I know the textbook answer for every single step of how we're going to administer insulin. One of the tricks, I guess, to this in answering in test questions is that it's actually not recommended anymore that we use an alcohol swab. If you look at the insulin pen here, the actual syringe that's going into this patient right now does not come with the pen. It comes with a kind of plastic cap on it, and then the syringe comes in a sterile plastic cap itself. So you actually pop the syringe on. The entire process is sterile, and so they've now started recommending that you don't actually have to use alcohol. But most organizational policies, hospital policies, are going to stipulate that you use alcohol swabs. So again, the answer is you don't have to use it, but also any hospital policy would override that, just in a test question. So this is what the pen kind of looks like. It can hold up to 300 units of insulin at one time. It's stored in a fridge, so most of the units will have a small fridge behind the desk or in the med room. And so if you look kind of up here, there's this little, what this is it's a little dial, and you turn it, and as you turn it, the numbers in this window change, and it's really cool. It makes a little clicking sound, so it's like click, 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 click. So if you were a diabetic who had, for example, some visual changes because of diabetic retinopathy, You could go by the sound of the clicking to know how many units you're prepping. So you have to give 7 units, it's 7 clicks, and you're ready to go. I'm sure that this has saved a number of lives. If you go and look at some studies, there have been a number of mistakes where, for example, physician orders 10 units and you have a student nurse or a newer nurse or a distracted nurse who reads that as 100 and gives 100. So just a heads up, 100 units of insulin is a lot of insulin. I usually will call and double check any order over 60, 65 units, especially if it's a patient I don't know well. So again, you guys know that most of my experience is in the ER and clinical resource team, meaning that I floated between units. What that means is that I didn't often have the same patients more than one day in a row, maybe 2 days in a row. And so this is a case where I see an order for 75, 80 units of insulin. I'm double checking that with the clinical lead on the floor or somebody else on the floor. And if I have to, I will call a physician just to double check. It's a lot of insulin. So that's how we use the pen. Nothing too difficult there. Again, I would make sure to go over all of all of the little rules and all of the steps before you write NCLEX. But other than that, it's pretty easy.